This video is about pudendal neuralgia, pudendal nerve entrapment, and pudendal nerve areas of entrapment or compression, and the different surgical approaches for these areas. Uh, I would advise everyone to also, after viewing this, to please visit uh, Dr. Lee Dellon's website. Dr. Lee is from Johns Hopkins Hospital. He's a outstanding nerve surgeon with major accomplishments regarding nerve decompression in all areas of the body, including the feet and all areas that have any kind of compression. Uh, his website is www.dellon.com, and then I'd advise you to go to his website and to click on at the top there of the page where it says Pain Solutions. Click on that and then go down to the bottom of the page after you do that to download and read his free publication there, which is Chapter 12, Pelvic Pain, which will explain in detail further everything that I'm discussing here regarding pudendal nerve entrapment and the areas of entrapment and the surgical approaches. Also, please visit www.pudendalhope.com for support and more information on pudendal nerve entrapment. Okay, just a little information for those who don't know about pudendal nerve entrapment. What is pudendal nerve entrapment? Pudendal nerve entrapment is a condition of entrapment of the pudendal nerve causing pain in the lower central pelvic areas. These are the anal region, the perineum, and the scrotum, and the penis or the vulva. Pain is worse usually upon sitting and less when standing or lying down or sitting on a toilet seat or cushion. These are the classic pudendal nerve entrapment symptoms. But there is no particular pattern that dominates. Pain can be in just one area, several, or all. It can be unilateral or bilateral, meaning one-sided or both sides of the body or areas of the body. In some cases, standing will relieve the pain, but lying down will not. Some of the PNE sufferers have used to describe their pain as stinging, burning, stabbing, aching, knife-like irritation, cramping, spasm, tightness, crawling in their skin, twisting, pins and needles, numbness, and hypersensitivity. Frequently, there's also urinary, anal, or sexual dysfunctionality. Pain is usually bilateral, the same on both sides if it's on both sides, or it could just be on one side. There are many other areas associated with PNE, such as internal organs or pain radiating down the leg, thigh. However, if the pain is not present in the classic areas, the condition is less likely to be PNE. It may be another nerve, such as the cutaneous nerves, or like the femoral cutaneous nerves, or it could be even a cluneal nerve in the buttocks area, or it may not be nerve damage related at all. It could be something else. So diagnosis is key, and making sure you rule out everything is key with the correct specialist and correct test. But for most people, you'll have pain in the perineum is the most common symptom. It's made worse sitting down and better standing up. Professor Robert from France writes, the main daily activities requiring the seated position, work, meals, driving, theaters, are no longer available to these patients whose mental attitude is one of chronic pain, suffer so obsessed with their miserable state as to be rapidly regarded by their doctors as psychiatric cases. The pain is sometimes so intense that suicide is considered. Uh, Everyone has different degrees of nerve pain or entrapment, so some people may have worse pain than others do, and you know, depending on your entrapment location, you'll have it. Some may have pain in different areas of your body and different symptoms also. Like some may have urinary symptoms, some may have uh, bowel problems, just depending on the entrapment location of your pudendal nerve. Since your pudendal nerve affects all the different areas and organs of your pelvis. Okay, pudendal nerve entrapment is frequently misdiagnosed as a number of different things. According to Chris R., a PNE sufferer and medical student at the Medical College of Georgia, U.S., and now a doctor, had this to say in 2002. Many PNE patients are originally diagnosed with one or multiple vague pelvic pain disorders before getting the correct diagnosis. The most common diagnoses are prostatidynia, non-bacterial prostatitis, idiopathic vulvodynia, uh, meaning unknown cause, idiopathic orchialgia, idiopathic proctalgia, idiopathic penile pain, Levator-Ani syndrome, and coccydynia. Um, there's other ones I'll explain also that is also misdiagnosed in my opinion as. The reason for these many diagnoses is that the pudendal nerves innervate urogenital and anorectal tissues, um, cutaneous skin tissue, and many small but very important muscles in the perineum. The muscles include the external anal sphincter, puborectalis portion of the levator-ani muscle, superficial and deep transverse perineus muscles, ischio-cavernous, bulbospongus, and the external urethral sphincter. Irritation of the pudendal nerves can cause muscle spasms in one or more of the aforementioned muscles. Spasm of the external anal sphincter can cause constipation. Similarly, spasm of the external urethral sphincter can cause urinary hesitancy, mimicking prostatic problems. Spasm of any of the other muscle groups can cause discomfort and a feeling of tightness, cramping, etc. Uh, Having said, I just want to also say that there's other misdiagnoses from my own experience. Uh, Another one is chronic pelvic pain syndrome, pelvic floor dysfunction, IC. A lot of the times, these can be actual symptoms caused, by pudendal nerve entrapment, instead of simply the own cause itself. So it's important, in order to correctly diagnose one of these other things I just mentioned, like IC or pelvic floor dysfunction, that you get a cystoscopy or whatever test your urologist or specialist recommend, to rule out those things. But once all those are all normal, especially pudendal nerve entrapment or pudendal neuralgia is definitely something that should be considered. Um, the correct question is not whether to operate or not operate, but as stated by Dr. Dellon, instead, the following three things should be considered. Number one, what are your symptoms? Number two, what exactly is your diagnosis? Number three, how can we treat it in the most safest, most effective way. Um, Something I strongly believe in it. The correct diagnosis is the key before any surgery and should be considered the last option. Once conservative treatment and uh, and all tests have been done. To first to rule out everything. So diagnosis is key. Um, and I highly recommend Dr. Potter, her MRI, Hollis Potter, mainly because I had one done here. It showed nothing. I went there and it showed my varices, which is a common thing that a lot of people with PNE find is varices or enlarged veins in the area of compression of the nerve. Um, and Showed some other things as well. She's one of the top, you know, radiologists in the country. I highly recommend her just based on my own experience. So, um, you know, in my opinion, a picture is worth a million words, and and something like this where it's hard to visualize the nerves very well and see the scar tissue, getting the best picture of your pelvis with the best MRI is worth more than just a million words, but it's worth $1 million to me. And I highly recommend getting one from Dr. Hollis Potter. Thank you, Dr. Hollis Potter. Okay, now I'm just going to give you a brief summary of what Dr. Dellin stated in his recent publication, Chapter 12, Pelvic Pain, from his website. The summary states, chronic pelvic pain can be treated non-operatively successfully in most patients with pelvic floor physiotherapy, medications, and treatment of associated problems such as interstitial cystitis, endometriosis, bowel problems, and depression. When these approaches fail, and especially with the history of trauma, the symptoms may be related to entrapment of the pudendal nerve, somewhere along its winding and variable anatomic passage from within the pelvis near the sacrum to the ischiorectal fossa to the pubic ramus and finally to the penis clitoris or clitoris. To determine the location of the entrapment, the history of the trauma, symptoms, physical findings, and the results of nerve blocks are critical. Those are pudendal nerve blocks. Recommended doing CAT scan guided for most accuracy. That was me, not him saying that. Based upon these determinations, a decision can be made as to the optimum surgical approach for a neurolysis of the pudendal nerve. In some people, more than one surgical approach may be necessary. One from the front at the pubic ramus and one from the back transgluteal or ischiorectal, requiring two different surgeries. There should be hope for relief in 80% of people. Okay, I'm just going to add a little bit something to what Dr. Dallin said there. Notice you mentioned, trauma. People with a history of trauma should especially be considered, as possibly having it. I personally know, people that have pudendal neuralgia or pudendal nerve entrapment that's caused by trauma, including myself. Most of the times, a lot of orthopedic doctors will diagnose people with pudendal nerve entrapment or neuralgia from bicycling because there's pressure on the perineum there. There's other, causes of it as well, such as I know people that have had it from weightlifting, sports injuries, falling down. That's all in the trauma category, I guess. As well as some people who have had surgeries, uh, such as for endometriosis or uh, any other female related surgeries down in the pelvic area, uh, such as hysterectomies. Also, childbirth with women, I've heard is another cause of this. So uh, there's many different possible, causes of it. I just wanted to add that, before my actual injury, which, has caused me to be in this pain in my perineum, um, and, causing urinary problems and stuff. Before this actual physical, and it was a physical instant injury, and that I felt a snap in a pool and a pain right there in my upper adductor perineum area. Um, while standing up against the current of the ocean from a squatting position. Um, uh, 3 months prior to that happening, or I'm sorry, it was actually 6 months prior to that happening. I just started having some urethral pain, but all the tests came back normal. Cystoscopy was normal, prostate ultrasound was normal. And then I got in this, and I was on antibiotics, but my urethral pain got better, but then, my urinary problems continued despite being on antibiotics for like 2 months and high dose ones like Levaquin and stuff. And the only thing that helped me to actually get better was a muscle relaxer, which relaxed the pelvic floor muscles. So that initially helped, whatever caused it to get better, whether it was some kind of infection or slight trauma to the pelvic floor. In the beginning, I don't know what happened, but all I know is it got completely better um, within about 4 months, I'd say. And then, 3 months later, after I was better, I had a physical re-injury while at the beach. Like I said, I stood up and I instantly felt a snap in a pool and a pain in my perineum and my left upper adductor area muscle, which connects to your pelvis bones, and it goes, over close to where your pubic ramus dorsal branch, of the pudendal nerve area is. So I just want to say, that there's many causes, and some may start out as a small infection or a small slight trauma and get better, and then you have a physical re-injury or something else later on that makes it worse. In my case, and a lot of other cases, it's a physical re-injury of some sort at some point. Thanks. Okay, now I'm going to talk about the different pudendal nerve zones or areas of entrapment. This uh, information is from Dr. Lee Dellen, from his website uh, at dellen.com, in his free publication that you can download under Pain Solutions. Um, Basically discusses the different possible areas where you can have um, you know the location of your entrapment or compression, um, classified in different zones. He also gives etiology of the entrapment, which is like uh, some possible known causes of it, and his surgical approaches for it. For zone one, um, he recommends uh, per zone one that which is within the pelvis area. Um, and zone one is also the area where the greater sciatic foramen area of the pelvis is at, and close to the sacrospinal nerves. Uh, the a common etiology of entrapment there is a tumor, and the surgical approach he recommends is intrapelvic or high lateral transgluteal. For zone 2, which is close to is actually where the close to where the ischial spine area of the pudendal nerve is located at. Uh, Basically, where the pudendal nerve goes in between the sacrospinous and sacrotuberous ligament. And that's the location of that zone there. The normal etiology, he says, is or common one is trauma, and the surgical approach he recommends is the transgluteal or the sciorectal fossa. Uh, and the sciorectal fossa, yeah. And for zone 3, um, which is at the entrance to the Alcox Canal. Looking at the picture there. This one is also the normal etiology is common one is trauma, and he recommends the surgical approach of the sciorectal fossa or transischial. Transischial, I believe he means the TIR approach is another name for that. For zone 4 is actually within the Alcox Canal. For that one, a common etiology is pelvic fracture, uh, and he recommends the TIR or transischial approach or the ischial-rectal fossa approach. For zone 5, which is at the area of the exit from the Alcox Canal, which basically includes the uh, the perineal branches of your pudendal nerves, the deep perineal nerve, the superficial perineal nerve, the bulbospongous muscle areas, uh, you know, all those are a very good coverage portion of your perineum there, in between your rectum and below your genital area. So for zone 5, he recommends, or the normal etiology is trauma, and he recommends his approach for that, which at the current time only him and Dr. Osmond, as far as I know of, Dr. Dell and Dr. Osmond can do this. And his surgical approach is called the Pubic Ramus approach. Anterior is another one. And zone 6 is the location of that is actually the pubic ramus canal, which is your dorsal nerve area of your pudendal nerve, the dorsal nerve branch of your pudendal nerve, which can affect your genitalia a lot and your you know and he says the etiology of entrapment is trauma, and his surgical approach again is the only one. Him and Dr. Osmond are the only ones who can do this that I know of, and it's called the pubic ramus approach or the supradorsal penile pubic, and the anterior approach. Okay, now I'm gonna go over the different zones of entrapment and the etiology or causes, common causes anyways, known causes. There's maybe some other ones, but the ones he states in here, and then also his recommended surgical approaches for these specific zones of entrapment while looking at the pictures itself. Okay, now I'm going to talk about the different pudendal nerve zones or areas of entrapment. This information is from Dr. Lee Dellen, from his website uh, at dellen.com, in his free publication that you can download under Pain Solutions. Um, Basically discusses the the different possible areas where you can have, um, you know, the location of your entrapment or compression, um, classified in different zones. He also gives etiology of the entrapment, which is like uh, some possible known causes of it, and his surgical approaches for it. For zone 1, um, he recommends uh, for zone 1 that which is within the pelvis area. Um, and zone 1 is also the area where the greater sciatic foramen area of the pelvis is at, and close to the sacrospinal nerves. Uh, uh, the, the a common etiology of entrapment there is a tumor, and the surgical approach he recommends is intrapelvic or high lateral transgluteal. For zone 2, which is close to is actually where the close to where the ischial spine area of the pudendal nerve is located at. Uh, Basically, where the pudendal nerve goes in between the sacrospinous and sacrotuberous ligament. And that's the location of that zone there. The normal etiology he says is or common one is trauma, and the surgical approach he recommends is the transgluteal or the sciorectal fossa. Uh, and the sciorectal fossa, yeah. And for zone 3, um, which is at the entrance to the Alcox Canal. Looking at the picture there. This one is also the normal etiology is common one is trauma, and he recommends the surgical approach of the sciorectal fossa or transischial. Transischial, I believe he means the TIR approach is another name for that. For zone 4 is actually within the Alcox Canal. For that one, a common etiology is pelvic fracture, uh, and he recommends the TIR or transischial approach or the sciorectal fossa approach. For zone 5, which is at the area of the exit from the Alcox Canal, which basically includes your the uh, the perineal branches of your pudendal nerves, the deep perineal nerve, the superficial perineal nerve, the bulbospongous muscle areas. Uh, you know, all those are uh, a very good coverage portion of your perineum there, in between your rectum and your below your genital area. Um, so for zone 5, he recommends or the normal etiology is trauma, and he recommends the his approach for that, which at the current time only him and Dr. Osmond, as far as I know of, Dr. Dellin and Dr. Osmond can do this. And his surgical approach is called the pubic ramus approach. Anterior is another one. And zone 6 is the location of that is actually the pubic ramus canal, which is your dorsal nerve area uh, of your pudendal nerve, the dorsal nerve branch of your pudendal nerve, uh, which can affect your genitalia a lot and your you know and he says the etiology of entrapment is trauma, And his surgical approach again is the only one. Him and Dr. Osmond are the only ones who can do this that I know of, and it's called the pubic Ramus approach, or the supradorsal penile pubic, and the anterior approach. Okay, next thing I was going to say is, that for many of us, it's hard to find a doctor, people that I know of who have this, and me included. It's hard to find the right specialist or doctor who is familiar with pudendal nerve entrapment or pudendal neuralgia. And the way I was actually diagnosed was through a sports medicine orthopedic doctor. After seeing multiple specialists, 5 different urologists, multiple ER rooms, and everything else. So if you're, you know, wanting to try to find someone in your local area who can diagnose you as having this, I'd recommend you try to see a sports medicine orthopedic doctor, and maybe call their office to see if they have any doctors there who are trained on how to recognize PNE, or pudendal neuralgia, and how to diagnose and to treat it until you get in with a specialist such as Hibner or Dr. Dellin or any other one. But basically, you can go to the website www.amssm.org, and you click on Find a Doc and do a search for a local sports medicine orthopedic doctor. But just be sure to call, and you can do a search, but by the state, instead of the last name, by entering the state abbreviation. Yeah, they're highly trained and recognized in treating that from sports injuries and bicycle injuries. You can also call their phone number to find one in your area at 913-327-1415. Hope this helps. One last thing, please consult your doctor before taking any action, and any opinions or advice given here are not a substitute for that of an actual doctor or specialist. And it's important, if you have any kind of symptoms that I mentioned here, that you see your specialist first, and you have to rule out certain things, especially if you have urinary problems and any other problems. You just want to make sure you check their advice first, and then if they can't find anything wrong with you, you've been to every other doctor, then consider seeing an orthopedic sports medicine doctor. Who can maybe diagnose you with a CAT scan, guided pudendal nerve blocker, or pudendal nerve motor latency test, or clinical exam, or however they want to do that. So. Anyways, for those who have been diagnosed with PNE or pudendal nerve entrapment, there's always hope, and never give up. Please try to spread awareness of PNE in any way you can, because too many people are just underdiagnosed or misdiagnosed for years. Also, if there was any mistakes in this video at all regarding anything I said or anything, it's not the responsibility of any of the surgeons or doctors or websites mentioned, but solely just a mistake on my part. So, and just also want to give credit to all the doctors and surgeons and websites, who have helped with this to make this possible. Thank you. Okay, so this concludes this video presentation on the pudendal nerve entrapment areas and the different surgical approaches for these areas. And also just want to say that to me, please take the advice of your doctors over any opinions or advice that I give, and to make sure you seek out their advice, the specialists and the doctors, and to make sure you rule out everything and work with them. But this is, mainly for those who've already been diagnosed, or who've already ruled out everything else by, working with these other specialists, as a method of helping them to understand uh, which different areas of entrapment, you know, uh, require which different surgical approaches. Um, Also, just want to remind you that if you have an entrapment, some branches, uh, you can have symptoms in other branches of your pudendal nerve. Like if you have entrapment of your Alcock's canal, you can have symptoms going, to your genitalia, or even at other areas. So I mean, this is based on if you know where your entrapment area is at, and that's best done by seeking out the expert advice of the pudendal nerve entrapment specialist, such as Dr. Lee Dillon, Dr. Osman, uh, Dr. Hibner, Dr. Conway, and Dr. Analog, and others out there uh, that specialize in pudendal nerve entrapment decompression surgery. But anyways, hope you all learned something from this, and there's always hope.